You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for December 6, 2019. This week, a potential new AFib drug called Vernakalent, cardiovascular death in patients with cancer, dapagliflozin data, sacubitril valsartan data, and more on words that harm and words that heal. And before I start, I want to say thanks to the Brazilian EP Society for inviting me to speak at their annual meeting in Salvador, Brazil. It was my first time to Brazil, and I made unforgettable memories. Now, I know that sometimes I take controversial stands on things, so it says a lot that leadership still invited me. Thank you to Dr. Saad, Diavila, Jorge, and Dr. Fagundes. A couple notables in Brazil. One of the sessions I spoke at was solely focused on a less is more approach to EP procedures, and the attendance was excellent. Now that was cool. Can you imagine a well-attended session at HRS or European Heart Rhythm on doing fewer EP procedures? I don't think so. Also, a special thanks to Dr. Luis Correia, who leads the Choosing Wisely Brazil movement and who took me for a run by the sea, introduced me to Dr. Anis Rossi Jr., who's a giant in the Chagas disease community, and for taking me around and showing me the beauty of Salvador. Thank you. Now let's start with the Vernakalent. It's a funny sounding name. It's an IV drug that blocks frequency and voltage dependent sodium channels, especially the late sodium current. Vernakalent also inhibits early activating potassium channels and the acetylcholine-dependent potassium channel, which are specific to the atrium. These electrophysiologic effects and atrial predominance give the drug its ability to terminate AFib of short duration. The drug has been approved in Europe for many years, but it did not pass FDA muster when it was reviewed in 2007-2008. Interestingly, the FDA advisory committee at that time gave it a positive review, but the FDA still did not approve it. Steve Stiles from the Heart.org Medscape Cardiology has excellent coverage of a post-European safety registry study called Spectrum that was presented at AHA. Stiles tells us that the Vernakalent drug will be reevaluated at an FDA Cardiovascular Renal Drugs Advisory Committee next week. At AHA, the Spectrum study reported on about 1,300 episodes of recent onset AFib treated in the emergency department. They found that conversion to sinus rhythm was achieved in 61% after one infusion of Vernakalent, and the remainder of patients went on to receive a second dose at 2 milligrams per kilogram, and the overall conversion rate was 70%. Now, there were 12 noteworthy adverse events in 11 patients, most of which were seen during the second infusion and included atrial flutter, bradycardia, and hypotension, but all of these without important clinical consequences. Now, unlike the current drug that we use in the U.S., ibutilide, there were no cases of ventricular fibrillation or torsade in the Vernakalent registry. It's an important issue because Vernakalent also blocks the rapidly activating potassium current, IKR, and that accounts for mild QT prolongation with the drug. This week, I reached out to an EP colleague in Germany, and he said it's approved there, but their hospital rarely uses it. He said other colleagues of his have used it and he knew of no major issues. The clinical trial program for this drug is pretty extensive. Numerous RCTs have compared Vernakalent to placebo in different settings, and one RCT compared it to amiodarone. The results of all these trials are consistent. Vernakalent results in conversion of AFib in slightly more than 50% of cases versus much lower rates with placebo or IV amiodarone. Now, two potential headwinds for the drug are its risk of hypotension, which is often present already in patients who have new-onset rapid AFib. And secondly, I would say that another headwind is the recent Dutch RCT published in New England Journal called the RACE-7 ACWS trial. And that trial compared early versus delayed cardioversion for AFib. And the wait-and-see approach or delayed approach involved initial treatment with rate control medications only and then delayed cardioversion if the AFib did not resolve within 48 hours. And the Dutch authors found that the presence of sinus rhythm at 4 weeks occurred in 91% in the delayed cardioversion group and 94% in the early cardioversion group, and that's clearly a non-inferior result. In the delayed cardioversion group, the group just given rate-controlling drugs, conversion to sinus rhythm within 48 hours occurred spontaneously in 69% of patients. So, stay tuned for more information on this story next week when we hear about the FDA Advisory Committee. Second topic concerns cardiovascular death in patients with cancer. European Heart Journal published an interesting study on cancer and heart disease epidemiology recently. This was from a Penn State group that used the SEER database, that's Surveillance, Epidemiology, and End Results Program, to characterize cardiovascular mortality risk for different types of cancer. Now, the results of their adjusted analysis reflect a new era of medicine. Among 28 cancer types in more than 1 million patients, only 38% died from cancer, but 11% died from cardiovascular disease. And in 8 cancer types, get this, cardiovascular disease mortality risk surpassed the index cancer mortality risk. As expected, though, patients with cancers of the lung, liver, brain, stomach, gallbladder, pancreas, esophagus, and ovary, they're least likely to die of heart disease because their cancer mortality is still very high. And cardiovascular mortality risk was highest in survivors diagnosed at less than 35 years of age, and the majority of deaths from cardiovascular disease occur in patients diagnosed with breast, prostate, or bladder cancer. Now, here are 3 comments. First, this is really good news that many cancers have been rendered into chronic diseases by modern treatment. It's never been a better time to be alive health-wise. Second, these findings underscore the benefits of continued vigilance and preventive measures for cardiovascular disease prevention in patients with cancer. Patients, like especially young ones with certain types of cancers, should be counseled not to run off the rails eating ice cream every day, and they should remain on a heart-healthy regimen. Third, and this is most controversial, but I think worth noting, long-term survival of certain cancers, say breast and prostate, should send a wake-up call to screening proponents. I was just at a meeting in which an administrator was emphasizing the monetary awards that doctors can reap if they get more of their patients into screening programs. Now, there were no awards for shared decision-making, only for those who get sent to screening. Yet, my friends, the better a therapy gets for cancer, the less important early detection with screening becomes. And I strongly suspect that many of these cancer survivors in this database have been labeled with disease by lead time bias and actually have what Gil Welch calls a tortoise type of cancer, one that is slow growing, and that detection of it really means not that much. Remember, screening programs not just for cancer but also for vascular disease, done in the name of prevention, may sometimes result in modest declines in death from that disease, but reductions in all-cause mortality are almost never affected by screening. And that's because, of course, it's pure folly to think that you can prevent dying from one disease when there are a gazillions of other diseases that can cause death. Third topic today is some great news in heart failure with reduced ejection fraction. At the AHA, Professor John McMurray from the University of Glasgow presented more good news on the SGLT2 inhibitor drug dapagliflozin in patients with heart failure with reduced EF. Recall that the DAPA-HF trial recently published in New England showed that the SGLT2 inhibitor, on top of guideline-directed medical therapy, reduced CV death and heart failure exacerbations by 26% compared to placebo. DAPA also reduced the risk of all-cause death by 17% without an increase in adverse events, a definitively positive result. At AHA, McMurray presented further data from the DAPA-HF's data set, and he started by saying they're struggling to find anything that doesn't look good. It's quite remarkable. Dapagliflozin's effect on the primary endpoint was virtually the same regardless of baseline glycosylated hemoglobin A1C levels. McMurray called the results mind-boggling because people thought the benefit of the drug would be seen more in patients with diabetes or prediabetes, but no, you see the benefits in people completely normal hemoglobin A1C. It's absolutely consistent across the spectrum of prediabetes, diabetes, and no diabetes, he said. Heart failure expert Dr. Larry Allen from the University of Colorado also offered positive comments. He said, "We know that these drugs are good options for patients with type 2 diabetes and heart failure, and after this trial we now know definitively that they're good drugs for people with heart failure and reduced EF but without diabetes." Now, a couple of safety points. McMurray said patients without diabetes were less likely to have any of the adverse events of interest that were pre-specified in the trial compared to patients with diabetes. In particular, patients on the drug without diabetes did not show a risk of hypoglycemia or diabetic ketoacidosis, which had been a concern. Also, he said there was no significant interactions by diabetes status for an endpoint reflecting worsening renal function. Now, also at AHA, there were two other sub-studies from the DAPA-HF trial presented, and both of these were published in Circulation. McMurray presented the effect of DAPA according to age. Now, we can keep this short. The drug benefited patients with heart failure with reduced ejection fraction at all ages. And notably, about 24% of patients in this trial were greater than age 75. The authors observed consistent hazard reductions for all components of the primary endpoint, all-cause death, and quality of life in all age groups, and likewise safety and tolerability of the drug versus placebo were observed even in the elderly. Another sub-study of DAPA-HF presented by Dr. Mikhail Kosoborid from Mid-America Heart, he presented the effects on DAPA on symptoms and quality of life. And here again, DAPA improved all key outcomes, including CV death, worsening heart failure, to a similar extent across all the ranges of baseline symptoms as measured by the KCCQ. DAPA improved all components of the KCCQ, and the effects actually got better over time. And finally, fewer patients on DAPA compared with placebo had significant deterioration of their quality of life. Next topic, and speaking of sub-studies of major trials, AHA also featured two sub-studies of the Paragon-HF trial. This was the RCT comparing sacubitril valsartan to valsartan in patients with heart failure with preserved EF. Again, these sub-analyses were also published in Circulation, and veteran journalist Sue Hughes has an excellent recap. Now, right away, we know these are going to be trickier to interpret because the primary endpoint in Paragon-HF, which was CV death and total heart failure hospitalizations, did not reach statistical significance. Of the 12 pre-specified subgroup analyses in Paragon-HF, only sex and ejection fraction appeared to modify the effect of sacubitril valsartan. McMurray reported the sacubitril valsartan reduced the rate of the primary endpoint by 27% in women, hazard ratio 0.73, but had no effect in men, hazard ratio 1.03. Importantly, the significant reduction noted in women was driven solely by reduction in heart failure hospitalizations. CV death and all-cause death were not different. Now, when the results were examined according to baseline EF, women showed a benefit of sacubitril valsartan across the range of EFs up to about 65%, but in men, the benefit was attenuated at EFs around 55%. Now, McMurray, the lead investigator, summed these observations up beautifully. He said, quote, "We are not sure whether the difference between women and men is a real finding or a chance finding." Now, he went on to offer plausible reasons for the potential interaction of gender, but then said, quote, "The possible modification of the effect of sacubitril valsartan by sex requires further investigation," full stop, end quote. Now, With that beautiful quotation, let's talk about the second trial presented dealing with sacubitril valsartan at AHA. This one from Scott Solomon from the Brigham Hospital, and this was a pooled analysis of Paradigm HF. Paradigm HF, remember, was sacubitril valsartan versus enalapril in heart failure with reduced EF, and Paragon, which was the heart failure with preserved EF trial. And this was an attempt to look at the effects of the drug across the whole spectrum of ejection fraction. Now, oh boy, right away you should note the challenge here because the two trials had markedly different comparator arms. And this is no small thing because a major critique of Paradigm was the fact that sacubitril valsartan faced a much weaker comparator, which was medium dose enalapril. So this analysis by Solomon combined 8,400 patients in Paradigm with about 4,800 patients in Paragon HF for a total of a little more than 13,000 patients. They then divided patients into ejection fractions separated by 10 points. There was about 6 groups. They then compared treatment effects for those randomized to sacubitril valsartan compared with RAS, renal angiotensin inhibition with enalapril or valsartan, overall stratifying by study and within each EF group and using a continuous analysis. This was a very complex analysis with multiple component endpoints, single endpoints, and it was difficult to interpret. The authors concluded that in this patient-level analysis of 2 pivotal trials, they observed overall benefit comparing sacubitril valsartan to RAS inhibition alone, but the findings were driven by benefit in patients with chronic heart failure and LVEF below the normal range. The benefit in the ejection range above frankly reduced but below normal was driven primarily by reductions in heart failure hospitalizations, and women derived more benefit than men. Okay, my friends, I really worry about this analysis. Sacubitril valsartan is tons more expensive than valsartan alone. Heart failure with preserved ejection fraction or heart failure with modest reduction ejection fraction is a much more common entity than heart failure with reduced ejection fraction. So the market is huge. There is no way sacubitril valsartan will get an indication solely for heart failure with preserved EF in general. But here, multiple sub-studies, one of gender and the other a combined analysis of 2 trials with different comparators, are being put together to find a group that might benefit from the more expensive drug. In both post-hoc studies of the non-significant main RCT, the benefit was seen only in heart failure hospitalizations. Neither of these sub-studies showed a change in death or CV death. Now, I'm sorry to sound cynical, and I'm even sorry to have to think this way, but I see such a combined analysis as too problematic to allow widespread use of this very expensive drug. Sure, yes, in a perfect world, one without spin and pharma marketing, and where all drugs were inexpensive, I could imagine an occasional patient who had heart failure with moderately reduced EF or even preserved EF and who had significant hypertension who kept coming back and having repeat heart failure admissions despite taking valsartan alone. Yes, this patient may have fewer admissions with sacubitril valsartan, but we wouldn't be reducing CV death or overall death. But that is not how medicine works today. If this drug gets in the guidelines or gets an FDA label on the basis of these post-hoc studies, it will be advertised and pushed on clinicians. To me, the onus is on the proponents to find a population that truly benefits from this drug. RCTs may be expensive, but far more expensive is the widespread use of a flat-of-the-curve medication. If you think women and patients with moderate reduction of EF benefit, the next step is to do an RCT, not a post-hoc analysis of a non-significant trial or the combination of 2 different trials with different comparators. Final topic today, Drs. Eric Topol and Abraham Verghese have another episode of the Medicine and the Machine podcast. This latest episode is one where they chat with Aliyah Crum, who has worked in the mind-body connection and placebo effects. This is a wonderful discussion for those of us who work at the bedside with patients. They talk a lot about the topic I discussed in Scotland, and that is how our presence as clinicians and our words can either help or harm patients. My friends, I have said this before, but I was shocked at how strong the objective evidence is for placebo and nocebo effects. Take a listen. These two giants of medicine have a great podcast, and this episode is especially good. That's it for this week in cardiology. As always, I am grateful that you listened. Thank you. And remember, if you like this podcast, please consider telling a friend, subscribing, and giving us a review. It helps other people find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.